Good morning. My name is Bridget Freyne, and I did my SBIT fellowship in Melbourne at the University of Melbourne, where I completed a PhD and worked at the Murdoch Children's Research Institute, investigating the immunological basis for the non-specific effects of BCG immunization in infants. I have nothing to disclose. So for those of you who don't know, the non-specific effects of BCG have been around as long as BCG itself. In this paper, published in 1931, Albert Calmette described 8,075 children in whom all-cause mortality was 4.6% in those who were BCG vaccinated and 16% in those who were unvaccinated. This caused Professor Calmette to muse that perhaps BCG conferred on the organism a special aptitude to resist infections that are so frequent in young children. The non-specific effects of BCG have come into the limelight again over the last 10 years, with emerging clinical evidence that infants who are BCG vaccinated have lower rates of all-cause mortality than unvaccinated infants. The WHO commissioned a systematic review published in 2016, which showed that in 5 studies of a moderate or low risk of bias, there was indeed a decreased relative risk of all-cause mortality in BCG vaccinated infants in a fixed effects model. There is also ample scientific evidence that BCG can lead to non-specific immune modulation in both in vitro and animal models of infection. And we reviewed all of this evidence in our papers published in Transactions in 2015. For my PhD, I recruited infants from 2 different settings. The first was the MISBEAR study, in which neonates were randomized to receive BCG or no BCG on day 1 of life. We looked at immune responses in 212 infants at 7 days and 167 infants at 7 months post-BCG vaccination. The second study was a cohort of older infants aged 6 months to 3 years of age who attended for BCG vaccination prior to travel. And these infants, we compared immune responses at 7 days and 3 months post-vaccination compared to baseline. In both studies, we used a whole blood stimulation assay containing clinically relevant heterologous pathogens and toll-like receptor ligands. And we looked at multiplex cytokine responses in both studies. In the baby bear study, we also looked at flow cytometry and RNA-seq analysis. As you can imagine, these studies generated a lot of data, and all of the immunological sub-study results have now been published in the Journal of Infectious Diseases from the MISBEAR study. I'm just going to take you through some of the highlights of our findings today. The first major finding that we had was that BCG vaccination did indeed induce heterologous cytokine responses in both neonates and older infants. In 7-day-old infants from the MISBEAR study, we found that those who'd been BCG vaccinated had lower levels of inflammatory chemokines, particularly MCP1, and also lower levels of anti-inflammatory cytokines such as IL-1RA and IL-10. We hypothesized that this would leave them with a pro-inflammatory bias, which would be beneficial in the context of infection, but also that they would have less damaging tissue inflammation mediated by chemokines. Interestingly, in the older infants, at the same time point, 7 days post-vaccination, they had a much more classical pro-inflammatory response, as seen by increased interferon gamma and TNF-alpha following heterologous stimulation. Really interestingly, in the same cohort of infants at 3 months of age, at 3 months post-vaccination rather, you could see there was increased interferon gamma following mycobacterial stimulation, but now there was a decrease in the pro-inflammatory cytokines TNF-alpha, IL-1 beta, and IL-6 compared to baseline. And this was accompanied by an increase in the anti-inflammatory cytokines IL-1RA, IL-10, and IL-8. Our second major finding was that BCG vaccination alters interferon gamma responsiveness to heterologous stimulation. This we mostly saw in 7-month-old infants from the MISBEAR study. And I'm just going to show you the individual level interferon gamma data from that study. As expected, following stimulation with BCG and MTB, there was an increase in interferon gamma responses at this time point in BCG vaccinated infants compared to controls. However, when we looked at heterologous stimulation, there was an overall decrease in interferon gamma levels in BCG vaccinated infants compared to controls. And what was really interesting was that it was clear that this was due to an increase in the proportion of infants who didn't mount an interferon gamma response at all. And the same was true following toll-like receptor ligand stimulation. In our published work, we displayed this by comparing the proportion of responders that existed between the 2 groups. As expected, following stimulation with BCG and MTB, there was an increase in the proportion of responders in the BCG vaccinated group, but the opposite was seen following stimulation with all heterologous stimuli. These effects of individual level heterogeneity of interferon gamma response has been seen in multiple other studies and may contribute to our understanding of why there is variable BCG vaccine efficacy between populations. Of course, we can't say whether this was genetically or environmentally mediated. Our next major finding was that heterologous responses to BCG are modified by sex and maternal BCG. When we think about the beneficial clinical effects of BCG vaccination on all-cause mortality, these benefits are greater in neonatal boys than girls. We found that BCG vaccinated boys had lower levels of macrophage inhibitory factor compared to BCG vaccinated girls. And MIF has been associated with a poor prognosis in neonatal sepsis. It's unclear why the status of maternal BCG vaccination would affect infant BCG vaccine or infant immune responses. But we did see this. In 7-day-old infants, we saw that they had increased responses of interferon gamma in response to MTBK and lower TNF-alpha responses following heterologous stimulation. These mechanisms are poorly understood, but definitely warrant further inquiry. Our final major finding was that there was a role for the innate immune system in the heterologous response to BCG vaccine. Looking at the whole blood transcriptome following BCG vaccination, we found 138 differentially expressed genes which had immune function. Reassuringly, there was an increase in interferon gamma at 7 days and a decrease in IL-1 beta and TNF at 3 months. This was in line with our cytokine findings and gave us confidence to look at other differentially expressed genes. We found 9 genes that were associated with an altered susceptibility to infectious diseases. 4, which were upregulated, were associated with a tolerized response to LPS or dampened inflammation and improved outcomes following infection, whereas 5 that were downregulated were markers of susceptibility to asthma or severe pneumonia or septic shock. In our functional gene set enrichment analysis, we found that pathways that were upregulated at 7 days were associated with complement activation and FcRI-mediated activation of NF-kappa-beta, as well as epigenetic remodeling. Pathways which were downregulated were associated with TLR signaling, interferon signaling, and neutrophil degranulation. The results of my fellowship will inform ongoing work on the non-specific effects of BCG. Probably the most notable effort in this area at the moment is the BRACE trial, which is looking to describe the effect of BCG vaccination on the development of severe coronavirus disease in healthcare workers. Having reflected at this stage on what science has gained from my fellowship, I thought it was also important to reflect on what I gained. The ESPID fellowship allowed me to develop as a female clinician scientist without putting my personal life on hold. I managed to get married and have 2 beautiful daughters in the time since I received my fellowship, and I don't underestimate the value of this ESPID award in allowing me to pursue my personal and professional goals at the same time. I also gained a wonderful group of friends and collaborators around the world, too many to thank individually, but I would like to give a special thanks to my supervisor, Professor Nigel Curtis, and also the ESPID board for this opportunity. Many thanks for having me speak today.